Look at me go.
And I've been having a little bit of screen trouble at my end too. So I'm just going to get you my slides here and you guys tell me if you can see everything. Can you see it and hear me?
I can hear you for sure, but I don't see your slides.
Okay, let me go again here then.
And if you need, I can always, perfect. There we go. Wonderful.
Okay.
So if you want to go ahead and get
All
started, I will
set.
just
Okay.
let people in.
All right. Very good. The last I saw, there were about 20. Maybe we usually wait a couple of minutes like you usually say. I'll wait till 6:02 and then kick things off.
Yeah, I just resent all the registration reminder emails, so hopefully some more will kick in.
Whenever you're ready, I think we can go ahead and get started.
We can go ahead. All right. Good afternoon, good evening, everybody. Welcome to this JVS Journal Club. Thank you for being here and joining. Thanks to the JVS for their encouragement of the young surgeon sections. Now on, you'll hopefully see a different face hosting along with Dr. Humphreys every month. So to kick things off this month, we have two papers. The glucagon-like peptide-1 receptor agonists are associated with fewer major adverse cardiovascular and limb events in patients with moderate peripheral arterial disease, authored by Dr. Catherine Go and Mohammad Islami. For our second paper, we have the outcomes of carotid artery stenting for non-atherosclerotic disease by Dr. Harabi and Dr. Kabani. Thank you for joining us. It always leads to a great discussion when the authors are here. Thank you to our presenters, Dr. Beatty and Dr. Mattis, and Dr. Patel and Dr. Ferris. And this is one of the surprising ones where the senior goes first and then the junior. So that's always fun to do in these presentations. Again, a big welcome to our guests, Dr. Go and to our authors, and Dr. Halavi and Dr. Shepherd, and also to our moderators, Dr. Sai and Dr. Greco. Just a few housekeeping topics before we get started here. Please do stay muted and feel free to submit your questions in the chat. The moderators pick them up and either discuss it or they may call on you to discuss the questions. The meeting is being recorded for on-demand access, and the dates and the hosts of the next few journal clubs are posted on the SVS site. Please stay involved and get as many of your friends, colleagues, juniors to attend as possible. And with that, I'll stop my screen share and hand it over to the first team. Let me know if you guys have control now.
Mark, do you want to go ahead and start? Johnny, you probably have to stop sharing.
Stop share. I think I did, but let me just make sure I did. I think I've X'd out. They should have control now.
Okay, there we go.
Is that full screen? No, yes?
That is, and if you
No?
want to put it in presenting mode, or go
Yeah.
ahead and make it,
There it goes.
wonderful.
Is
Looks
it good
good.
now?
Mhm.
Mhm.
Okay. Welcome, everyone. My name's Dr. Mark Matos, and I want to thank the JVS for allowing us to sort of host the online journal club. It's been a year or so since we did the last one, and we're always appreciative when we get that call. My fellow who's going to present the content of the paper today is Dr. Jason Beatty, who's a PGY7 vascular surgery fellow. And we're going to be discussing the outcomes of a paper from the JVS 2025, volume 82, page 907 to 14. It's called The Outcomes of Carotid Artery Stenting for Non-Atherosclerotic Disease. First author is Dr. Halabi, and the senior author is Dr. Lloyd Kabani from Henry Ford Hospital, our colleagues about 60 miles south. So carotid endarterectomy is the long-established strategy for stroke risk reduction in patients with atherosclerotic bifurcation disease. Carotid artery stenting is an acceptable, less invasive alternative initially for high-risk patients, but then moved into the standard risk patients with the atherosclerotic bifurcation disease. And it came in two forms, initially from a transfemoral approach and then more recently from a common carotid approach, or TCAR. And the data would suggest for atherosclerotic bifurcation disease that actually TCAR is superior to transfemoral carotid stenting and probably equal to carotid endarterectomy. But what about, the authors asked the question about what about non-atherosclerotic carotid disease? Does the same paradigms for treatment hold true? And if so, why? And if not, why not? The ones that they focused on in their paper are carotid dissection, carotid trauma, and carotid fibromuscular dysplasia. You have to know a few things first, as before Jason gets into the paper, that non-atherosclerotic carotid disease is fundamentally different from atherosclerotic disease. It's a different disease mechanism. It's pathophysiologically unique to each of the three. They're not alike, and they each of them have anatomically diverse locations, which then play a role in which procedure is most appropriate and is going to have the greatest benefit for the patient. Carotid dissection, you get intramural hematomas, intimal teres, false lumens, distal embolization, and you can see here in this shot that if you were trying to do a carotid stent, either via TCAR or transfemoral, that you might have some challenges as you see this dissection wrapping around. If you're doing a carotid dissection, whether or not you can be able to get your wire up. If you're doing a transfemoral, where are you going to place the filter? For carotid trauma, unfortunately, like what happened to Charlie Kirk today, you're going to get wall disruptions, bleeding, pseudoaneurysms, and thrombosis. And you can see on the slide on the left that there's only a very irregular lumen. And then in the middle, in the last slide pane, you can see that there's really no endpoint that you're able to place your wire for your TCAR, not understanding whether or not you've got a zone 1 hematoma there. And then if you're doing a transfemoral, whether or not, where are you going to put your filter again? How are you going to be able to identify whether or not you're open? Challenges from the endovascular approach that you don't have sometimes in the atherosclerotic disease patient, but you certainly do in the non-atherosclerotic patient. And then finally, fibromuscular dysplasia, which is defined by medial fibroplasia, intimal fibroplasia with abnormal wall integrity, excessive medial fiber proliferation with intervening medial thinning, producing stenosis occlusion, and extended treatment lengths, which is different than your atherosclerotic disease. Each of the three have extended lengths, which we'll see in the paper and what they described in the discussion, leads to a greater number of stent placement, which then also calls into question the cost of doing this procedure. So the study aims, before Jason gets into it, was to compare the outcomes in these three disease etiologies with TCAR versus transfemoral stenting. They really wanted to determine if the results could help guide physicians make evidence-based decisions, and they really wanted to determine if the advantage of TCAR extended to the non-atherosclerotic disease state in patients. So with that, hopefully that sets the tone for the paper done by Dr. Halabi and Dr. Kabani and the group and Henry Ford. Jason, you want to take this now?
All right. All right. So I'm Jason Beatty, the second year fellow at Michigan Vascular Center. Thank you, Dr. Meadows, for that introduction, and JVS for this opportunity. So we'll start just going into the design of the paper. So this is a retrospective review, prospectively collected data from the VQI using the carotid artery stenting module, which collected data up to 18 months, or like midterm results. Now, all patients who underwent carotid artery stenting for non-atherosclerotic disease were captured from the years of 2016 to 2024. And those disease processes, as Dr. Matos has gone through, were dissection, trauma, as well as fibromuscular dysplasia, FMD. And these were categorized into which procedure was performed. Is that TCAR with full reversal or transfemoral carotid artery stenting with distal embolic protection? Exclusion was prior carotid endarterectomy, really to not muddy the waters with a prior intervention in that area. So again, sorry for the busy slide here, but patient variables really can summarize it by just saying that the typical demographic as well as comorbid variables were identified and evaluated. And then there were carotid artery stenting related variables like high anatomical risk factors, as well as degree of ipsilateral contralateral stenosis, and then operative details, anesthesia type, technique, fluoroscopy and procedure times, contrast volume, as well as length of stay. Now, the outcomes were both primary and secondary outcomes that were evaluated. Those primary outcomes were stroke, death, as well as major adverse cardiovascular events, or MACE. Secondary outcomes were perioperative complications, as well as restenosis. Statistical methods employed were for the categorical variables, chi-square test. For a lower number, the Fisher's exact continuous variables were identified and analyzed with students' t-tests, as well as Mann-Whitney U for the lower number, as well as multivariate analysis, which was done by logistic regression. So the results, there were 676 patients captured from the VQI dataset. TCAR patients, there were 173, and there were 503 from the transfemoral carotid artery stenting group. Now, you'll see that the TCAR patients were older, they had more comorbidities, and were on more medications than the transfemoral group, which you can see in this table. Now, I know this is a very large table. This is table 1 from the manuscript, so I distilled it down into the statistically significant variables, which were 13. And as I summarized before, you can see here in a numerical representation that, again, the TCAR group is older, had more comorbidities and medications. Now, looking at table 2, this contains the operative details between transfemoral carotid artery stenting and TCAR. And the statistically significant variables were anesthesia type. So the majority, or the very large majority of the TCAR patients underwent general anesthesia versus transfemoral stenting. And then fluoroscopy time was shorter for TCAR, 5 minutes versus 18 and a quarter. Contrast use was lower for TCAR group versus transfemoral, 30 versus 95 milliliters. And length of stay was lower by a day for TCAR versus transfemoral. Looking at table 3, which is postoperative outcomes, again, distilling it down to a little bit more digestible chunks. For the overall group, stroke was lower for TCAR, stroke death combined, MACE, hyperperfusion syndrome, as well as death. And again, that's just summarized on this slide here. And in a graphical representation that wasn't in the manuscript, but I think it's quite striking for the bar graph, you can see that TCAR benefited from having less MACE, stroke death combined, stroke, and then death in solely. And these really extended onto the asymptomatic cohort as well as symptomatic cohort, but I won't go into all the details of those to save time for the discussion. Now, looking at table 4, that's a multivariate analysis, and that does show the TCAR is protective in a couple of these variables, being the stroke death combined variable, as well as MACE, with the odds ratio of 0.11 and 0.09 for stroke death and MACE, respectively. Now, looking back to the etiologies, dissection, trauma, and fibromuscular dysplasia, in table 1, these are displayed, and I just distilled that table back down to the etiologies, and you can see that dissection was really the lion's share here of etiologies of 78%, really for both transfemoral and TCAR cohorts. Looking at the etiology, you can see that stroke rates between groups were not statistically significant, and really the statistical significance was here with the mortality. So the highest mortality for etiology was the trauma group. You can see 8.3% versus 2.7 and 1.3 for dissection and fibromuscular dysplasia, respectively. Perioperative complications trended towards being higher in trauma, but those were not statistically significant. Looking at the Kaplan-Meier curve in the or the survival table in the manuscript, you can see the restenosis rate at 18 months was the highest for fibromuscular dysplasia. And this is just graphically represented by a bar graph here, showing that 29.2% of the FMD group were experiencing restenosis at the 18-month mark, or the midterm outcomes, versus 11.5 and 0 for dissection and trauma, respectively. Strengths and limitations for this paper. Strengths is a large multi-center data set. VQI is a very robust tool to use and gives us good data. It's a real world contemporary practice, and you can see that the adjusted analysis did support the results of the unadjusted, meaning that we're not looking at just confounding variables, but really the independent protection or protective value of TCAR versus transfemoral. Limitations could be that it's a retrospective design, so there's selection bias always. And then there's limited granularity of the data for VQI in the carotid artery stenting module, and specifically in the detail for trauma being either penetrating versus non-penetrating. My suspicion would be that most of these are non-penetrating. And with the fibromuscular dysplasia group, as this excludes, by the nature of the carotid stenting module, any angioplasty only cases, which would be the first line for fibromuscular dysplasia. There's also limited follow-up, 18 months, and that nearly 80% of the population of the patients were carotid artery dissection. So generalizability is not as high as it could be, but this is also for etiologies that are more rare, and I think it'd be difficult to really capture a large amount of those patients. Conclusions from the authors is that superior perioperative outcomes were experienced in the TCAR group versus transfemoral in the treatment of non-atherosclerotic carotid disease. And when an endovascular approach is indicated, TCAR may be the safer option and more effective for revascularization, supporting its adoption as potentially the preferred option over transfemoral. And here we'll bring it over to open discussion for everybody.
Great. Thank you so much for the presentations. We have a couple questions already from the chat. The first being if the authors could sort of explain the life table a little bit more. Which table is this, Dr. Matos?
I think he's talking about
It's the table figure. Yeah, my question to Loy and Dr. Halabi is that at time 0, the numbers for dissection, trauma, and fibromuscular dysplasia are 96, 10, and 24, which is far lower than the numbers originating for each of those 3 different categories. And I wasn't sure, and I didn't see it in the results section, how you came about that. So I don't know if you guys can answer that. It's an important concept, but I just don't know where the numbers came from.
Yeah. I'm gonna let you answer that. I presume time zero is probably the first, these are months and not days. So especially the trauma patients, I presume it's very difficult to follow up. So you don't have follow up at 1 month. You're gonna be dropped very expeditiously. Hamad, do you want to comment on that too?
Yes, Dr. Kabani, you're right. So 0 is 0 months. The follow-up for all the patients was limited. The number of patients that did complete follow-up was also limited. That's why the number at risk is very small when you compare trauma and FMD to dissection. We can see that it starts off with 10 and is 10 throughout until month 12. That's just because the number is very small. And that's why sort of we see a straight line for trauma. So it's
Yeah.
months,
Okay.
and then the number of risk is just because it's a small population.
Right.
And
I mean,
something
my
that's-
my prop. Go ahead. Sorry. Eli.
Yeah, so we don't go 0 for the date of the procedure. We go 0 for the end follow-up at 1 month is what Hamad's trying to say. And we have the same problem when we look at the trauma registries. It's very difficult to have any type of meaningful follow-up when you look at the National Trauma Registry. They just don't come back.
Right.
Another
Yeah.
Great. Another interesting question from the chat is regarding the treatment of FMD. Usually angioplasty, but in this case, a lot of stenting. Just thoughts about stenting for FMD and the note that they also had a high rate of restenosis.
Yeah, we had the same question we were scratching our heads is who would stent FMD? The standard of care is built a simple plain old balloon angioplasty. But again, this is a stenting registry. So people who are entered into the registry are people who had a stent. We don't have the people who underwent plain old balloon angioplasty. And I think there's two parts of this. When you look at FMD, there's probably a subset of these patients that had carotid webs that were classified as FMD. And the people with carotid webs, there is no subcategory for that. And we all know that if you have a carotid web and a symptomatic carotid web, if you just balloon it, that web's just going to come back and doesn't really break off. So the standard of care for carotid webs is actually to do a stent. The other thing, these are probably people who have FMD and had maybe a balloon angioplasty in the past and then had recurrence. And therefore the treatment would be a stent. I don't think people primarily stent FMD, at least that I know of, but I'm interested to know if anybody does that at all. I think those are the two reasons that we had. And the high recurrence rate is probably if these are people that have complex FMD that didn't respond to balloon angioplasty, they're probably at the more complex end of the FMD spectrum. And therefore have some kind of atherosclerotic disease or fibrosis disease going on. And that's maybe why they have a high incidence of restenosis at 18 months of 28%. But again, it shows you stenting is probably not a good solution for FMD looking at this data.
Thank you. You know, I have a question myself. What do you think is the mechanism why TCAR does so much better? Or do you think there is some bias in it? Because I think when you do the retrospective study, there's going to be some indications you don't get. Like, you know, a lot of the time we'll do transfemoral stenting if there's common carotid disease, but you'll never get that out of the VQI. So I wonder if there is something else about the people who got transfemoral stenting that made them higher risk. Like they were clearly, you can look at their medicines and say they had more medications, or you can look at it and say they were better medically managed. More of them were on dual antiplatelet going into it than, you know, the ones who got transfemoral stenting. So I'm just wondering what you think led to this big difference in results.
So there's 2 points. No matter how much you try to match these patients up, you can't match for everything. I think you alluded that, Dr. Tsai, because there's always something that you miss. And you could see that with the ASA score. People who had TF-CAS had a higher ASA score than the TCARs. So we're definitely missing something that we can't measure with all the variables that we have, even though the hypertension and other comorbidities were higher in the TCAR group. So definitely the trauma patients may be a little bit sicker, but there's something that we may be missing. So I tend to agree with you that this may be there may be something that we miss in that. But at the same time, you can't deny that there's a five-fold increase with complications with TCAR compared to TF-CAS compared to TCAR. What we can definitely say, I strongly believe this, TCAR is at least as good as TF-CAS, and people tend to shy away from TCAR in these patients. You got get a trauma patient anyway. Well, it's a trauma. I'm going to cut down on the neck, and I'm going to get into trouble. But I think this should encourage us to at least consider TCAR as a line of therapy. And if it's not, there's data that this data shows that TCAR may be even better. And like Mark very nicely presented in his prelude to this, where are you going to put the filter in these patients, right? If you have a dissection, you're going to put the wire and the filter all through that dissection. I think you'll get into trouble. Same thing with muscular dysplasia. And same thing for the dissections. So I think TCAR probably gives you a line of protection that we can't really measure very well. Most of these patients are going to have a normal arch, but getting the wire and the filter across the disease is going to be problematic. And most of these patients were symptomatic. So again, you're dealing with an unstable carotid artery with clot in it, and you're putting a wire through that to put the filter in. I think you're going to knock something off.
I think we have one more question, time for one more question. Any thoughts about the cost issues between the two, the difference in cost, especially if they place more than one stent?
Yeah, you have to place more than one stent in both of these. And Hamad, you can help me out. I think the number of stents placed were equal between the two groups, correct?
They were not statistically different, no. So.
Yeah. So I think the number of stents, these are just like Mark again alluded to in his very nice prelude. These lesions are much longer than the atherosclerotic lesions, and 25% of these lesions need 2 stents to cover the whole lesion. Again, it's a very different disease than atherosclerotic disease.
Oh, I guess one more. Did the antiplatelet mix for TCAR include loading? So, the table just said preoperative aspirin, preoperative platelet Plavix, but then what about, do you have an idea of how well these patients were loaded with DAPT before their procedure? Probably hard to tell from the VQI.
Yeah, we weren't able to tell from the VQI. It's not that granular, so we wouldn't have that information.
Should we move on to the next one? Thank you.
Very nice job, you guys.
Thank you.
Okay, can everybody see my screen and hear me okay?
Looks great.
All right. So my name is Mead Ferris. I'm a vascular surgeon at the University of Vermont. And on behalf of our group here, just want to extend a sincere thanks to the JVS editorial board and specifically Dr. Humphreys for inviting us back again to participate in the online journal club. Along with my senior fellow, Dr. Nathan Patel, we have the privilege of introducing and presenting this month's Editor's Choice article by Dr. Go and colleagues. Glucagon-like peptide 1 receptor agonists are associated with fewer major adverse cardiovascular and limb events in patients with moderate PAD. I will be honest with you, I feel that personally I'm late to the game in learning about these medications. I'm not that far out from med school and training and don't remember this coming up at all, but like most of you, treating our patients, you see the prevalence of these medications and the frequency that they're being prescribed. So for example, just last week, I was seeing a patient 2 years out from a carotid endarterectomy for symptomatic disease who's doing fine. And she tells me in the last year, she's lost 80 pounds on Mounjaro. may have to apologize to Dr. Matos for jumping on this article, but it seemed like a good opportunity to kind of learn about this. So thanks again for including UVM. So what are GLP-1 receptor agonists? I mean, there's a slew of them on the market. You're probably familiar with the names or seen the commercials. Mounjaro, Zepbound, Wegovy, Ozempic, Rybelsus. They're all over the place. And they're quickly, we're quickly learning about the benefits of these medications beyond the treatment of diabetes mellitus and obesity. And they're becoming mainstream. In 2024, the creators of South Park dedicated an entire episode to the end of obesity using semaglutide. So I'm going to use the next few slides just for if anyone else out there like me who's not quite familiar with these medications, you know, what's their role and kind of where are they going here. I believe this is the first article in JVS kind of looking at these medications specifically. So semaglutide is marketed under Ozempic for diabetes mellitus, and that was FDA approved in 2017. It's marketed as an oral form Rybelsus for diabetes mellitus in 2019, and Wegovy for the treatment of obesity that was FDA approved in 2021. Eli Lilly came out with tirzepatide, which is a similar GLP-1 receptor agonist that also has a dual function for gastric inhibitory peptide. And this is marketed as Mounjaro for the treatment of diabetes mellitus that was approved by the FDA in 2022, and Zepbound for the treatment of obesity that was approved by the FDA in 2023. There's a few other GLP-1 receptor agonists on the market and a lot of other pharmaceutical companies looking to get in the game, given the benefit that these medications have been shown to have, as well as the market share. So how do they work? Well, GLP-1, glucagon-like peptide 1 hormone is naturally released by the gut in response to glucose ingestion. And that results in increased insulin production, decreased glucagon secretion, and decreased gastric emptying. And this leads to early satiety, weight loss, and improved glucose regulation. And so the original FDA approval was again in helping people with diabetes mellitus type 2 and better glucose control. But since then, they've seemed to be very effective in the treatment of obesity. Additionally, extensive research has been done over the last several years looking at the other effects that are sometimes coined as pleiotropic effects, similar to statin medications. And so this figure depicts, you know, the other actions of GLP-1 throughout the body, you know, so some examples of decreased inflammation in the immune system, decreased steatosis in the liver, and the cardioprotective effects of this hormone on the heart. And the mechanism of action hasn't quite been clearly described, but it's thought to improve vasodilation and microvascular recruitment. So, you know, from a vascular surgeon's perspective, that makes sense. And potentially this could be used for, you know, treatment of peripheral arterial disease. There's multiple studies that have come out over the last several years, again, demonstrating effects of reduced MACE events in patients with diabetes mellitus, improved or decreased risk of progression of kidney disease in patients with chronic kidney disease and diabetes mellitus, and even in the treatment of obstructive sleep apnea. Well, what about, and because of this, you know, the FDA extended approval for some of these medications. Again, Zepbound has been approved for treatment of obstructive sleep apnea in 2024. Wegovy for reducing the risk of cardiovascular disease and diabetes mellitus in 2024. And Ozempic and reducing the risk of progression of chronic kidney disease and cardiovascular disease most recently this year. Again, you know, this makes sense to me as a vascular surgeon. This could potentially be effective medication in the treatment of peripheral arterial disease and other vascular pathologies. And there are starting to come a few studies looking specifically at the use of these medications in the treatment of PAD, one of which was published in The Lancet earlier this year and the STRIDE trial. So this was a blinded, prospective, randomized trial looking at patients with diabetes mellitus and PAD with claudication, and the use of semaglutide given on a weekly basis over the course of a year. And the outcomes were, you know, the maximum distance walking before onset of symptoms, And as you can see from the figure to the right, and there was significant improvement in patients treated with this medication. So I'll turn it over to my fellow to present the article.
Yeah, seeing my screen. My name is Nate. Thank you, Dr. Ferris, for the kind introduction. And like Dr. Ferris says, I am even closer to graduating medical school, and I had not heard about these medications at all. A resident actually just called me, who was on research, and said, "Hey, what about GLP-1s and PAD?" And I was like, I had never heard what he was talking about. And so then when I saw this article, I thought it was a good time to review as well. This was a article written by Dr. Go, the first author, Dr. Islami from Charleston, West Virginia. There was a multi-center retrospective propensity score match study using the TriNetX database, which is a generally ICD code-based database. It's very large and encompasses 102 health networks. What they did is they found patients with ICD 9 and 10 codes for PAD. Then they had ABIs between 0.4 and 0.9 and 1 year follow-up within the study dates. And the exclusion criteria are listed there, but essentially no venous disease, no wounds. And then the dates for inclusion were October 1st, 2022 through December 31st, 2023. And the covariates that they used for the propensity score matching are listed there, the usual atherosclerotic risk factors. So using the TriNetX database, they were able to identify patients that met the criteria for PAD listed prior, and then whether or not they had GLP-1 agonist exposure versus no exposure. And they defined the exposure as either prescription code documented at baseline, and then at least once during the follow-up period to kind of asked to see if the patients are kind of continuously taking this medication. The primary outcome was 1 year overall survival, 1 year MACE, which was they defined as MI, cerebrovascular accident, or congestive heart failure exacerbation, and then 1 year major adverse limb events, which was major amputation or acute limb ischemia requiring intervention. Secondary outcomes were all-cause inpatient admissions, inpatient medical or surgical complications, and then number of patients that have required an endovascular peripheral intervention. And these were all based on ICD codes. Here's a list of how the patients were selected. There ended up being about 858,000 patients with that qualified as moderate PAD, of which 55,041 had exposure to GLP-1, and using propensity score matching, they were able to identify and match an additional 55,041 patients that had no GLP-1 agonist exposure and were qualified as moderate PAD. These are the characteristics of the patients, kind of highlighted the more significant ones, but tended to be younger, in their early 60s, slight female predominance, but almost 50-50. Interestingly, about 75% of patients were on GLP-1 agonists, had diagnosis of diabetes. And then statin use was nearly universal among these patients. Looking at the baseline ABIs, about 0.73 at baseline in the patients that had agonist exposure, 0.88 in the control. And then at 1 year, they had an increase. They didn't test the significance, but it was kind of interesting to note that was in the control group was essentially normal. Did have a standard deviation of 0.3, so certainly patients that fell down. And then the weight was a little higher in the patients that were on GLP-1 agonists at baseline and at 1 year, and then also increased A1C at baseline and at 1 year. So a slightly sicker metabolic group. Looking at the overall results, there was these are the Kaplan-Meier curves with Cox regression analysis to get a hazard ratio. The 1 year mortality for patients with GLP-1 agonist exposure was 1.7 compared to the control of 4.4. That had a hazard ratio of 0.4. And then the MACE, combined MI, cerebrovascular accidents, and congestive heart failure was 25% for the patients with GLP-1 versus 29%. That was statistically significant as well. And as well as the major adverse limb events, acute limb ischemia or major amputation. The numbers were quite small, so 0.8% patients that were having a GLP-1 agonist exposure compared to the control, which had a 1.46. Looking at secondary outcomes, you can see an inpatient hospital admission was statistically significantly decreased, 17.9% in 1 year for GLP-1 agonist exposure compared to control of 26.8. Inpatient complications were also decreased 21% from 30. And then endovascular interventions, the number of patients in either group was 1.3 and 1.5%. There was no statistical significant difference between those two patients. So conclusions, GLP-1 receptor agonist was decreased with all-cause mortality, the major adverse cardiac events, and major adverse limb events. They did do a subgroup analysis looking at whether or not patients were diabetic versus non-diabetic. And then within those groups, whether or not there was GLP-1 exposure versus not, they still had a statistically significant protective effect. It was slightly higher in diabetic patients. It was the GLP-1 agonist seemed to decrease the risk of MACE and MAL greater than the non-diabetics. And then the same thing was seen in men versus women. Men who had exposure did have a protective effect, as well as women who had exposure. And then inpatient hospitalization and complication were both decreased in the treatment groups. And then, as expected, a small portion of people were receiving endovascular intervention. And then, in conclusion, despite having a worse metabolic profile, as we saw earlier, they had decreased AVIs, they had improved or decreased or increased A1C. They still had fewer cardiac and limb events. Limitations, the race, renal function, income level, insurance status, and most other medications were not included in the propensity score matching. This was something that is a little challenging, can be challenging to get out of the database. And then the post hoc rate of statin use was similar, but they did not look at other drug medications, beta blockers, antiplatelet, or anticoagulation. And then the exposure for the GLP-1 did not include dosage, duration, or the indication for which these patients were on them. So 25% of patients in the group that had a GLP-1 receptor agonist exposure did not have a diagnosis of diabetes. As we've seen, is pretty new for other indications, either obesity. Some of these patients certainly there are patients that take this, pay out of pocket and don't have a specific diagnosis. Survivorship bias, patients that did not survive to the 1 year mark, or patients that got an intervention. They did do an analysis where they took out the patients that had an endovascular intervention, and all these results were still similar. And then, of course, all the issues with a kind of retrospective database. And then overall, we know these patients come to your clinic, and the biggest thing we always talk to all patients with claudication is lifestyle modification, smoking cessation, walking, exercise, and weight loss. And none of these were able to be quantified in the database. Next steps, I think this is, very fair to say, this is one of the first papers to describe specifically in peripheral arterial disease. Almost all the other papers reference diabetes. This one was focused on limb events for patients with peripheral arterial disease, and hopefully developing next steps for a randomized controlled trial in peripheral arterial disease to see if this effect holds true. Thank you.
Great. Thank you guys for the background, which was excellent. And then, of course, the review of the article. I'm seeing a lot of dollar signs in the chat box here. It's expensive in Canada too, so don't worry. Can the authors comment, like, are these patients paying out of pocket? Is insurance paying for this? How sustainable is this? And I guess one of the questions would be, if the medication stops, we know, for example, that the weight comes back if someone's taking it for weight loss. Do we think that maybe the same is true for the effects of protective effects of MACE and MAL?
Hi, everybody. Thank you for the invitation, and thank you for that great discussion. I'm Catherine, or Dr. Go from CAMC in Charleston, West Virginia. So absolutely, very expensive medications. I struggle with that myself with patients. The way I've been addressing this, I don't prescribe it myself. I'm a vascular surgeon. I have basically our weight loss clinic and some patients' PCPs on speed dial, essentially, and we kind of communicate either through Cerner or just privately on our cell phones kind of referring patients to the weight loss clinic. Hey, can we start the conversation about these GLP-1s? What does their insurance look like? And is it something that they would qualify for based on their BMI or their diabetes status? The Trinetics database unfortunately does not allow us to capture dosage. And as was discussed, only 75% of the patients that were included were diabetics. So there were 25% of patients who were not diabetic on GLP-1s. So they must have been receiving these medications either through a different, like a compound pharmacy, or obtaining it privately. So we can't really comment on that, although there is some research going on in terms of who are the patients that need this the most, and do they have access to it? It's absolutely a very important question. Thank you.
Great. You mentioned you don't prescribe it. Does anyone in the group right now, does anyone prescribe it? I mean, as vascular surgeons, we prescribe a lot of other medications, statins, maybe antiplatelets, etc. This is not one that I personally have started prescribing yet either. In fact, I always forget to stop it 4 or 5 days ahead of time before surgeries, which is also another problem for someone who needs an urgent intervention, for example, and because of the delayed gastric emptying, at least at my hospital. I'm seeing a lot of nods, like no one's kind of prescribing it. Okay, and then, again, kind of along the same lines, about 10% or so of patients expect or have severe side effects that need to stop the medications. Was this accounted for? Again, were we able to capture that in the database of who stopped it and who maybe didn't have that 1 year?
Great question. We were not able to capture that based on Trinetics database. It's kind of a yes, no, were they on it at the start of when they were included, and at least one point in the 1 year period. So unfortunately, we were not able to capture patients who discontinued the medication.
Okay. In terms of next steps, should we be actually prescribing this, or should we all have someone on speed dial to maybe, like, are we as a group deciding that this is where we're going next?
I think it's a great time to get involved with a multidisciplinary PAD center. I have partnered with our local PCPs, endocrinologists, podiatrists, and our weight loss clinic to kind of make a multidisciplinary limb salvage center. And so that's where we're headed. I think more involvement by all physicians and care providers can only benefit these patients.
Right. I found it interesting that in your multivariate regression analysis, that male gender was always sort of picked out as higher was associated with a higher risk of MACE or male, whereas a lot of the times in PAD studies and aneurysm studies, it's actually the female sex or gender that tends to do worse and is always a risk factor for sort of worse outcomes. But your study kind of found the opposite. Can you comment on that?
That's a great point. I actually had not really focused on the gender except for performing that subgroup analysis, but that's definitely something I can look into. Thank you for that. I think what was the most surprising for me was the fact that patients who were non-diabetics also benefited from the GLP-1 medications.
Mm-hmm. And so, I mean, we saw that there was maybe a study coming out with the STRIDE trial. Did the database pick up like how many of these patients were symptomatic, and then, with the increase in the ABI, were they not symptomatic, or was that again something that maybe not picked up by the database?
Unfortunately, it's not picked up by the database, and it was funny that the STRIDE trial, the data had not been published yet at the time that I was writing this, so I was unable to actually quote the STRIDE trial entirely. I just kind of mention it and say that they were finished enrolling, and we were waiting excitedly for the results. But unfortunately, we were not able to capture symptom improvement.
Okay. Well, I mean, because numbers are great, but it's nice to see if the patients are actually, improving from it from a physical point of view. A comment here, I guess, does anyone feel it's maybe more related to the weight loss and ease of walking more so than any other underlying? I think the drug does a lot of underlying things, so it could be maybe a mix of both.
I absolutely agree that it's a mix of both. I think it's everything, and I think I chose to focus on this population because I feel like this is the group that we can affect with lifestyle modifications and medications. So, if you get the rest pain group and the tissue loss group, you're going to have to intervene. But these claudication patients are ones that we can potentially keep as claudicants or better, and prevent them from progressing to rest pain. So this is why I wanted to focus on this group.
Right. So we looked at the mild and moderate group in this study. Is there plans to do a similar study in the CLTI group, or maybe wound healing or something along those lines?
So there was also a venous ulcer group that is being written up right now, is presented at SVS, which did show improved venous ulcer healing. And we did look at weight loss. And we looked at both starting weight and the actual weight loss, which is a little bit difficult to capture in trinetics. So we know that there is an effect, an interaction between starting weight and weight loss that does positively improves venous ulcer healing. And then our next steps are working on the CLTI group.
That's great. I think most of the chat here is again more about the cost of the drug and exercise, etc. Where's the compounded pharmacies that you can get this at? Excellent. Compliance. Did you find compliance was an issue? I guess, again, that's not really captured in the database.
Correct.
I can speak to the cost, as I kind of saw a couple of facts on that if you'd like me to, but yeah, it's expensive. Mostly in the United States, of course. And I believe the Ozempic, someone quoted about $1,000 a month, and Wegovy is approaching $1,400 a month. And the biggest problem or barrier is the lack of coverage. Somewhere they quoted about 50% of private insurers will provide some sort of coverage. There's no coverage by Medicare Part D, and very few like state-sponsored Medicaid plans cover this. So the patients that typically need it, like, our patients, they are, underserved, poor resources, they don't have the coverage. And so how are they going to afford the medication? And that's going to be a big problem going forward, and to disseminate it against, for these patients that may benefit from it.
Actually, I invite all of you to come to West Virginia, and you see all these clinics that are all over the West Virginia, and most of them are usually there are car parks in the parking lot more than any other place. So some of our patients manage to pay for it. And I think our wonderful RFK, I guess he's the Secretary of Health and Human Services, is preferring to have this in the water and removing the fluoride if you let him. So there may be movements in providing coverage down the road, because our president also would benefit from it. Thank you.
Very interesting. Yeah, it's expensive in Canada as well. I think it's probably on the same order of magnitude in terms of a couple $1,000s a month. And I know there's a lot of people who are not necessarily overweight or with diabetes that are wanting to take it for weight management. I was at a conference a couple of months ago, and they're saying that diet and exercise really don't work for anything, including obesity. And really, this is the next drug and next steps in terms of how to treat whether it's obesity or diabetes and cardiovascular disease. This is just sort of another drug in the armamentarium, the same way as we would prescribe aspirin for patients with PAD, for example. This is another one that should be on the sort of regular list of prescription medications that we're giving these people. I don't know what people have. I thought people have thoughts about that.
I think when they were alluding to potentially a randomized control trial in the future, I mean, this is kind of where we're headed, and that is this part of best medical therapy for these patients.
Yeah. So I think it's very sort of astute for all of us to kind of get used to these medications. One, when to stop them if we are still stopping them. I saw Misty put in there. I would love if our anesthesiologist got on board and made us not stop the medications. but also then to be maybe comfortable starting to prescribe them if this is something that's going to be sort of regular use in our patient population.
Don't expect a clinical trial anytime soon. I mean, these medications are supposedly used by about 20% of Americans. So, you know, it's unbelievable, and there's no real incentive to do another trial for it because everybody wants them.
Great. If there's no other questions, oh, the next generation, fewer side effects. Well, that's always good. That's like the statins, right? They have fewer side effects than newer ones. Maybe, Misty, we can wrap up slightly early if there's no other questions.
Yeah, I want to thank everybody for being here. It's always a lot of great conversation. I will find out where the compounding pharmacy is, and I will put that in the link for the next JVS Online Journal Club. So feel free to show up in October, and you can all learn where to get GLP-1s from the compounding pharmacy. Thanks again to our authors, to our presenters, and to our Young Surgeon Society host, Dr. Sen. We'll see you all in October.
Bye. See ya.